one lecture?
Okay.
Are they just going in order?
I'm not, you know, that's a good question. Do you have them all up there?
I can pull it up.
All right.
Yeah, there was one on like the maxillary and.
Yeah, the maxilla, the mandible, basic growth processes, I think they're talking about that. The very first lecture, I'm not sure there is a video.
No, the first lecture did have a video.
Okay.
It was for each one that.
There was one called Basic Growth Concepts, I think, but maybe not. I saw the one from last time because it had the eraser and the bone, right? I hadn't watched it for a while, it was pretty good.
Yeah, so this was the.
Growth of the midface.
So that was one that.
That's probably both, right? Growth of the midface is probably, that's a lecture video. Are these the short ones or the long ones?
They're like.
Yeah, that's what you want.
Long.
See what I'm talking about.
Oh, yeah, this is the one where you came in and you're like, that's a weird mask.
I had to get some production, value.
I have an effort into it.
Yeah, so there's a lot of production value on this one.
He's like wearing this little
That's right, yeah.
mask on. He's like,
remember
I didn't
this
want
one,
you to
yeah.
get too bored with the same face. No,
Right.
that's it's the mandible one.
Growth of the midface has the mask.
And
Yes.
then on the syllabus, it was like it was basic.
Yeah, but this is it probably. Because there's a slight difference. I probably didn't do one of these.
She's still out of it. She,
Because I'm using I think I'm reading
did I tell you?
the.
She was really
So
confused
we'll see.
between MD and D.
Okay, there might not be one.
She's like,
I
what?
forgot about that one. That was pretty good.
It was very
That's one is the yeah, there you go. That's what I said. That was funny. All right, any other questions about that? So there might not be a video called Basic Growth Processes, just so you know. There's one called Growth of the Midface, which is probably combines maxilla and basic growth processes. Okay, other questions?
I have one about.
Quiet for a minute.
I had one about the cartilage and bone growth. So at the epiphysis, you said there was like a cartilage that wrapped around it. You drew like a picture kind of like that.
Oh, yeah, that's a good point.
And
There's two kinds of cartilage in the long bone.
yeah,
There's the kind that's at the end,
yeah.
which people call hyaline cartilage, right? And that one has lots of what they call ground substance, right? Like lots of like proteoglycans, and just a few cells. Because the main purpose of hyaline cartilage, the main purpose of articular cartilage, is to resist the muscular contraction force and resist gravity. So when you look at them in the microscope and you see this ground glass appearance, and then Dr. Chandler asks you what that is, and you say hyaline cartilage, that's correct. Okay, and if you say, I think if you say articular cartilage, it's correct too, because hyaline and articular are sort of the same thing. And then there's this thing people call fibrocartilage, and that's basically hyaline cartilage with more fibers in it. It's a little more fibrous. That's why they call it fibrocartilage. And then the one that has all the cells and not much stuff, that's growth cartilage. Okay, which people also say, you know, like the epiphyseal growth plates. So growth plates, growth cartilage that's made that's only there when you're rapidly growing, okay? And so all the long bones have it, and when you're done growing in your height, right, called statural height, that cartilage then, it goes away. So in an adult, there is no growth cartilage in the long bones. Does that help? So the one on the end is articular cartilage, and it's on the end of all bones all joints. All joints are lined with articular cartilage, right? Doesn't matter what joint. We'll talk more about the temporomandibular joint, but basically all joints are lined with cartilage, and then some joints, like your knee and the condyle and the temporomandibular joint, have also cartilaginous discs, which people call menisci. Right? Your knee has several menisci. Okay, the cartilage, and then temporomandibular joint just has one, and we'll talk about that. So, who can tell me what you're doing when you do a face bow? Why are you even doing it? Why do you do a face bow? What? Yeah, but why are you doing a face bow? Who knows? All right, I'll tell you why. All right. All right. Because if you just look at a model of the teeth, right? So if we, I don't know if I have any dental models, but I must have something here. Okay, well, here's some teeth. Okay. If I just look at teeth, okay, and I just look at like the models of the teeth, like when you take impressions, okay, it's not oriented to anything, right? There's no orientation. It's just teeth. You know, so if you just have a model like this, okay, it's great if all you want to look at is the teeth, all right? However, one of the things that we're sort of interested in is how the teeth fit in the person and how the jaw works, right? So we know from Posselt's diagram and studies that the jaw articulates like this, right? And we know that you can, have you done Posselt's diagram? Okay, but basically you know that the temporomandibular joint's a hinge like this, and you can also jut your jaw out, right? But so the question is, how do you capture the relationship? Whoa, right, grab that. That was a bad one. How do you capture that? Too much coffee. How do you capture that relationship of the teeth to the head? Okay? So how do you capture the relationship of the models of the teeth to the rest of the head? Okay? So that's what you're doing. So the first thing you did, yes?
So we mounted the mandibular based on MICP, but if a patient were to have like an asymmetric jaw, how would you?
Okay, let me start with the first thing you did probably was you took the upper jaw and you oriented it to the rest of the head. That's the face bow transfer. So what the face bow transfers, where's that skull I almost dropped? Okay, here it is. Okay, so what the first thing you did is you pretended that the face bow was the head, okay? And you put the end of it in the ears, right? Okay, so you use the ears as the anchor for the head, okay? And then you took the upper teeth and you related how far the upper incisor was from the ears, which we use the ears because that's pretty close to where the condyle is, right? So we're trying to find out what where the center of that hinge movement is of the lower jaw. So we're trying to figure out how things rotate, right? Because you know how arcs are. Like if you had a door that was at half the length of that wall and you opened the door, the arc would be different than if you had a really short door, right? It's a sharper arc. The same thing with teeth. You know, the further the jaws are away from the hinge, the broader the arc. And the shorter they are, the arc changes. So what you're trying to do is get an idea of what is the arc of closure. In other words, how do those teeth come together? So the first thing you do is you fix the upper jaw to the head. Okay? So what you did was you used the ears to represent the head. And then you took the upper teeth. And then what you did is you knew you didn't want it like this, right? You knew somehow it had to be oriented to where someone was looking, so you used the infraorbital point right here to orient it like this. So you oriented it forward and back, the upper jaw, based upon the ear, and the tilt based upon the orbit, which is essentially along the line of sight. So the first thing you did was you took the upper jaw and you put it with the head as it is in that person. Okay? And so for a non-growing person, like an adult, like you do each other? Or you just did some random person? Oh, mannequin, okay, so the mannequin would work, the mannequin's not growing, right? So basically, you've got the mannequin and you orient it like that, so that you basically said, how is this upper jaw forward and back with the relationship to the head, and how is it tilted like this with the relationship to the eye? Those are the first thing you did. So now, you have the upper jaw related to the head. So the next step is, how do we relate the lower jaw to the jaw joint? And what you did there was, you took a piece of wax or something, right, and you sort of did an index of how the person closes their teeth together. And so now what you did was, you took how the teeth fit together, okay, and then you know how the articulator has, you know, articulators are weird because they're upside down, right? I mean, if you really had an articulator that was like a person, it would be the lower member that moves, right? But in an articulator, it's the upper member that moves, right? So it's a little goofy like that. But it's essentially because it's not practical to do this. You'd have to be working on the patient upside down or something. So because it's not practical, generally, it's upside down. So when you're opening the articulator, you're doing this, right? And when you're closing the articulator, you're doing that. So by putting the teeth together first, then you essentially stuck the lower teeth to the bottom part of the articulator. And that represents this part. So the lower member of the articulator represents the lower jaw and the teeth. And the upper member of the articulator represents the head with the upper teeth. So what you've done is you've now oriented these things so that they're not just anywhere in space. They're a certain way, right? And so that when someone's closing their teeth together, you've got the right arc of closure. Does that make sense? You know, you don't have half a wall, you've got just what your patient is. So you say, why does it make a difference for dentistry? Well, because you know that you can detect when you put something about 1/10 of a millimeter difference in your pipe. And some people maybe even more. So dentistry, when we talk about teeth fitting together, it's incredibly precise science. So that's why we do these things like that. It seems like, oh, maybe can we just take these, just work with them like this? Not really, because you need to be more precise. So that's why you do the articulator like that. Okay? And then if you can even get more involved, some of the articulators actually have a way to capture the shape of the glenoid fossa. And then you build in the shape of the glenoid fossa into that too. You know, there's different settings. I don't know what kind of articulator you're using. But you know, some of the articulators are really, you can set the angle of the eminence and how much shift you have and all these things. So what they're trying to do is get a mechanical instrument that represents a human being. A friend of mine used to say that the study of humans and articulators is really the idea of how do articulators chew, how do they eat, right? Because they're not really a real person. So but you're trying to get something for dentistry that you could use. Right? Why? Well, because to do dentistry, you've got to be able to solder and wax. It's impractical to do it in the mouth. Right? So some stuff you got to have sort of done before you get there. Right? You think this is probably who we're going to have? Looks like okay. So let's start. Now you at least learned something about that. Okay. So that's why you did it, and it does connect to facial growth. Oh, I dropped the spring. And this is to represent on the skull the masseter, right? The pterygomasseteric thing. You don't have any muscles on your articulator. You provide the little muscular force. So, last time we talked about bone, and we talked about cartilage, and we talked about how these tissues are the structural tissues in the human body. Okay? Not only in the face, but they're the structural tissues for the whole human body. And we talked about how the reason why cartilage is more flexible, okay, and can withstand pressure is because cartilage, you can diffuse nutrients into the cells, right? So the process of diffusion happens within the extracellular matrix of cartilage, whereas bone has to have a capillary going to each cell. Okay? So that's the difference. Bone is much more rigid, and it has to have this highly vascularized capillary system. And so what happens is, one of the hallmarks clinically for you to remember this, we talked a little bit about don't scrape the periosteum, right? Because it has the nerves in it. Now, so the question is, you're at a soccer game, and a kid comes down, and they fall down, and they want to know if their leg is broken. How do you tell the difference between a break and a sprain? X-ray is one, but you want to have an X-ray in the field. Mobility is one, but the most common one is this. If you break something, you've broken all of those capillaries, and immediately, within 60 seconds, you're going to get a big bulge because it's bleeding. Okay, and it doesn't stop bleeding until the pressure of the interstitial fluid equals the blood pressure, right? That's when it clots. So when you break a bone, it's just like turning on the blood faucet. Okay? There's just tons of blood, and that's one of the ways to tell. But remember, bone is very vascular. It really doesn't resist pressure very well. Cartilage is very avascular, so it's really good at resisting pressure. Okay? Just remember that. Now, when we were studying how the human face grows, we said in the very, very first class that because the primacy is on the cranium, the head's really big, and the face is relatively small, right? So we've got this little face and we got this big head. And last time we talked about how bone can only grow on the edges, right? We talked about how everybody here, we've got a lot of dead cells today. So we'd have to go in and get the cutting and filling cones to come in and fill all the other chairs. So, but we talked about how the face starts out really small, okay, really small like this, and it proportionally changes. In other words, it's not just like we take the baby's head and we blow it up to adult size. There's a picture in the book of that, where if you took a skull, an infant skull, and you blew it up, it looked ridiculous. It looks like a Martian or something. So what's happening is we have growth of the face, but we also have development. So we've got differential growth. Now, what's the general pattern of facial growth in terms of direction? Downward, forward. Okay? So in general, we know when we see people that, boy, the chalk is not working great, is that the face is growing downward and forward in the human head, right? So the face is growing downward and forward. We use the term growth, and we want to now refine that, okay? So the growth is the general term, or growth and development is the general term. So if somebody says, how does the face grow, and I ask you that on an exam, you can say, Dr. Hines, the face grows directionally downward and forward. Right? And this is one of those things, remember the first day I said, you're going to have to memorize some things because they don't make sense. Right? Patients do not understand why, if I'm looking at this kid, okay, and I'm seeing the face getting bigger, okay, why aren't they outgrowing this problem of their teeth? Okay, why don't people outgrow crooked teeth? And well, by the end of this class, you should be able to answer that for your patient. So if they say, you know what, I think John's going to outgrow this, doctor, you'll be able to say, well, I don't think so, and this is why. Okay? So stay tuned on that. We might touch on it a little bit now. But we talked about bone growing only on the edges. So when bone grows only on the edges, what we said was we've got deposition of bone, and we've got resorption of bone. And we said this can happen on the two edges. So one of the edges, we called it the periosteum, right? That's the outside. And the other one we called the endosteum. So when we talk about bone growth on surfaces, we're talking about deposition on the periosteal surface, which we then call periosteal deposition. Okay? We could also get deposition on the endosteal surface, which we call endosteal deposition. And then we can get resorption again on the outside, or we get resorption on the inside. So those are the four processes that we have. Those four processes. There are two deposition types, and there's two surfaces. There's deposition, resorption, and there's two surfaces. So there's four possibilities. So when a bone is changing on the edges, we know it's changing. By definition, it can only change by these four processes. Deposition and resorption, either on the endosteal or the periosteal side. Now, that type of surface activity of bone is one of the major ways bone change, and one of the major things that happen as the face grows out from underneath the brain downward and forward. So one of the major things that happen is this process of deposition, resorption, periosteal, endosteal. And we have a name for the whole process. Okay, the whole process we call bone remodeling. So bone remodeling refers to the surface activities, whether it be periosteal deposition or periosteal resorption or endosteal deposition or endosteal resorption. When we're talking about remodeling, we're talking about the whole thing. Okay? So if I asked a question of you, how does the face grow downward and forward? What are the processes? And then you said, I want you to then say something about growth. What would be one of the ways bone grows? Bone remodeling, exactly. So one of the things would be remodeling. So remodeling is these surface changes that are on the happening. Now, just to illustrate this, I brought out this podium, really noisy podium, and my table here. Okay. So let me take some people here. How about everybody on the edge, so I don't always pick on the people in the first row. So if you're on the edge, we can get out here, or easy, come on up here. That's probably enough. Line up or walk in front of this table. Good, that's good. Okay, part of you are going to be cells, part of you are going to be cells in this bone. So the two of you are cells in this bone. Right there, okay? You're a little bit, you need to, let me see, maybe we don't need you. All right, so, yeah, get in there. All right, so basically, if you look from behind, we've got two bones. We got the podium bone, okay, of which we've got a couple of osteocytes that are in that bone. Okay, imagine that there would be more, but the bones aren't that big, and they're too big, and the people are too big, and the bones are too small. So we would need little mini people. But imagine that these two people are there. Okay, notice, what did I say last time about when we study bone? If you look at a bone on an X-ray, you can't tell anything. Why? Because in order to really understand bone growth, we have to know which cells are where in the bone. Okay, they have to be labeled. So that's good here, because we got this guy here and we've got this guy here. Okay? When?
Yes.
Okay, good. Joe?
Got it.
Okay, so we got everyone here. And then this bone, the big one we'll call the table or whatever, okay, that has individual osteocytes. Okay, now, one of the things that can happen is we can have remodeling activity. Remodeling activity. So, if we look at a bone at one point in time, and then later, the bone is bigger, okay, we don't know if this bone got bigger because, I don't want to pick everybody in the front row. All right, somebody, come on back, come on down. Oh, I'm sorry, we eating? All right, come on down, because you've got a good vest on. All right. All right. Get right in here. Right in here. Okay. All right, let him in. Okay, so now, this bone is bigger, right? Okay, and we know, because we know the cells that were in this bone, okay? And so we know that this guy somehow ended up the bone being bigger, right? Remember, we said something about bones can't push on other bones. Why can't a bone push on another bone? Why can't bones push on each other? Why do we have cartilage? What's the reason we have cartilage? Because bones cannot resist pressure. So bones can't push on other bones. Okay? So some mysterious force, and we're not sure what it is, separates the bones just a little bit, so you have a suture, and all of a sudden you get a new osteocyte. Okay? Now, you guys are still part of this bone. We're trying to get it. All right, so now you can see that this bone is bigger. Okay? So the question is, as we're looking and trying to figure out what's happening with bones, we know that one thing that's happening is, like for example, this guy could get resorbed off, he's gone, okay? Now there's just a single cell here on the edge, right? How do we know that he's gone? Well, only if we had a label, because in the x-ray they all look alike. Right? So we know that, I'll use you again. Okay, so imagine he was not on that end of the bone. But all of a sudden now, we add him here, okay? So if we add in here, and then, which bone are you in? I think you're in this one, all right. And we took this one out like that, okay? We could make the bone effectively move that way, couldn't we? Because now imagine this is not the same, what's your name? D'Angelo. Imagine this is not D'Angelo anymore, okay? That osteocyte that was over there, okay? But imagine he's a brand new osteocyte, an osteoblast coming in and being an osteocyte. Notice now, this bone's getting bigger, and if I take, what's your name? Demore. What is it?
Timor.
Timor. Okay, Timor, right here. And he goes back into the bloodstream. Okay? So now, effectively, this bone has effectively moved down the room. It's moved. It looks, the whole bone now is moved, right? But it's moved by surface activity. Okay? So when we look at bones moving in the face, changing in the face, one way they can change is by this addition and subtraction of cells on the surface. And when a bone moves that way, okay, we call it remodeling. Okay, remodeling. So it remodels, okay? And we only know that remodeling is occurring if we have the labels. Because otherwise, we can't tell the difference. So we can't tell the difference, for example, if the whole bone is relocated like this, by itself, all your cells come with me. Okay? Except for the cells in the other bone. So all the cells. So now, in other words, I see all the cells moving together. I know it's not remodeling, right? Because what happens with remodeling? I'm adding and subtracting cells. Here, the whole bone is moving. The whole bone is moving. That type of movement is called displacement. Displacement. So displacement in terms of bone growth is the movement of the entire bone. The cells sort of are in the same place. So movement of an entire bone is displacement. Remodeling is a change within the bone at the surfaces. So there's two basic processes as we talk about this huge complex face and how we talk about how it's changing, and it's so intricate and it's very complicated. Okay, it's very complicated. And that's why we have to begin to sort of understand this remodeling process and the displacement process. Okay, so displacement is what? The whole movement. Okay? If I just add, come on back, you're back. The suture here, you're displacing it apart, and the question, and we're going to talk a little bit about what causes that movement, right? But what happens is once it gets displaced, then the cells on the edge can fill in. So essentially we get the displacement and then we get new cells. And we don't know if there's more cells being added on this side or more cells being added on this side, just by looking. Okay? All right, everybody can sit back down. Good job. Thank all the cells. All right, all the cells. So, yes. What way to, because you're getting bigger. All right, now, the interesting thing we talked about, if this is the maxilla, all right, let's just say this is the maxilla, and we've got the palatal right there, okay? Now, if the maxilla as a bone is moved away, then the movement of the entire bone is called primary displacement, because it's the movement of this bone itself. That's primary displacement. Primary displacement has to do with the movement of the bone you're talking about, no matter what it is. Could be the mandible, could be the maxilla, but any bone, if you're talking about primary displacement of that bone, it's movement of the bone with that name. Okay? Now, remember that in the head, all the bones are sort of connected together, aren't they? Right? So it's not, we don't have any gaps when you look at somebody's head. So the palatine bone is sort of, there's a suture. Okay? So imagine that the palatine bone is now displaced. Is this primary or secondary displacement of the palatine bone? Primary, because we're talking about the displacement of the palatine bone. Now, notice that the maxilla also moved. Right?
Yes.
What do we call that? It didn't move the whole bone. Secondary. Exactly. Sometimes that's hard to understand because especially, we're talking about as the bones, it's going to start in the cranial base, right? So you get changes there, they cause changes here, they cause changes there, and everything's connected together, so it's a chain reaction. And what makes it really difficult is that not only is this happening, right? And sometimes we get primary displacement, and then at the same time, obviously, we're getting remodeling because we never see big gaps like this. So the bone growth processes that account for everything we see are remodeling and displacement. So if I ask you, how does the face grow out from under the brain? You could say, Dr. Hans, it grows out from underneath the brain by the processes of displacement and remodeling. And they're occurring sort of simultaneously. Yes?
What is the impetus of displacement?
What causes it? And that's the million-dollar question. In the face, I have to tell you, no one's exactly sure. In the long bones, remember we talked last time? And I said, if I was training you to be orthopedic surgeons, we'd have been done talking about growth growth in that last lecture. Would have been one lecture. Because the long bone growth is basically, you got the end, right? You got the diaphysis, you got the growth plate, right? Like that. Right, you got this. So in a long bone, what's causing the displacement of the epiphysis, which is a bone, right, away from the diaphysis, what's causing the displacement here and here is clearly the growth cartilage. So clearly in long bones, it's the growth of the growth cartilage. But look at the face. We don't have growth cartilages. We don't have those sorts of things. So it's more complicated. What are the forces? Because we know one thing it can't be. It can't be just the bones growing and pushing against each other. Now why is that, Sam? Why can't the bones push against each other?
They're connected in Weird ways.
They're connected in weird ways. And what happens when you push on a bone? You compress, you can shatter it, but you remember it has that periosteum, and the periosteum is squishy. And if you push on it, you squish the blood vessels. And if you squish the blood vessels, then there's no nutrients. And if you cut off all the nutrients, what happens to bone? Dies. There you go. That's pressure necrosis, right? So what I'm saying is bone is really lousy at resisting pressure. And the bones are put together in these really complicated ways. And in the beginning, people thought, well, it makes sense. Why doesn't the bone just sort of grow and push it? Well, because it can't. It can't generate what we call a tissue separating force. Force to separate or move two bones apart. So, just as an aside, how much force do you think the epiphyseal plates in the long bones of a human can generate? How much separating force? Anybody have any idea? What's the purpose of it, first of all? Why do we have growth cartilage? Why do we have that? Why do we have to separate? We have to grow the bones, but we're resisting what? Gravity. Generating pressure, resisting gravity. So it must have something to do with how big the person is, right? Because it's got to be able to lift the person, right? I mean, essentially, or at least resist that amount. So it turns out that for growth cartilages in humans, okay, we're talking about a force in the hundreds of pounds. Okay? It's incredibly strong. Now, they tried to measure this, and there won't be any exams or anything, but they tried to measure this first in cows. And so they put a strain gauge and a growing calf across the growth plate, and they tried to measure how much force it was, and the strain gauge broke at 200 pounds. Because it turns out, since cows are bigger than humans most of the time, they can generate like 400 pounds of force. So it's incredibly powerful, this tissue separating force, the ability of the cell of the cartilage to push apart. We don't have that in the face. So in the face, that's a big question, is what is causing the displacement of the bones in the face? There's one other thing that we need to cover, and that is displacement, primary and secondary, remodeling, and then the last thing is to understand that there's a difference between bone remodeling and biochemical remodeling. This type of bone remodeling has to do with structure. This type of bone remodeling has to do with biochemistry. Remember when you were taking cell biology, and you remember that you had these calcium gates in the cells, and you remember that, like, you had to have a certain pH in the bloodstream, and to keep the calcium gates open, okay? And so the calcium has to come from somewhere. So you have to be able to get calcium from somewhere, and you have to be able to put calcium away when you have too much. So if you have too much calcium, you can put some away, and if you don't have enough calcium, you need to get it from somewhere. Right? For a long time, people thought that it came from the teeth, right? Because people would lose teeth when they were pregnant, blah, 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 all these things. We know now that that's not true. First of all, there's not enough calcium. And second of all, that most dental diseases are infectious diseases. The calcium in your bloodstream comes from bone. So bone, in addition to being a structural tissue providing rigid support, is also the reservoir for calcium. We put calcium in, we take calcium out. Okay? Now, the surface changes we call bone remodeling that are there for structure probably don't have much to do with calcium homeostasis. Okay. calcium homeostasis has more to do with the internal remodeling of bone. So one of the ways we talked about bone remodeling internally is with dead cells. And how do the dead cells get replaced? Remember? Remember that histologic structure? Cutting and filling cone? Okay? I mean, cutting and filling cones are important because that's how you repair bone, and that's how you integrate implants, and it's how you can put calcium into the bloodstream and out by turning it over internally inside the bone. So internal bone remodeling has a lot to do with calcium homeostasis. Okay, so today we wanted to cover the deposition resorption, which I talked about last time, and together to realize when we see that happening, we call it bone remodeling. Okay? That we use the term bone remodeling, but there's also biochemical remodeling, so there's two types of remodeling. One has to do with calcium homeostasis, the other one has to do with changing the shapes of the bones. Now, very interesting work was done here at Case Western Reserve back in the last century, where for a long, long time, people thought that as you got older, your skin changed, but your bones didn't. So there always was a question of, when does the skeleton stop growing? Especially when does the human face stop growing, but the whole skeleton too. So they did studies here looking at people when they were 18 and 25 years old, and then they looked at them when they were 50 and 60 and 70. Okay? And what they showed was, in fact, there's bone changes and growth that occurs after age 25. Okay, now, when I say bone growth now, you probably immediately thought, I wonder if that's displacement or remodeling, didn't you? That was the first thing that came to your mind. Is it displacement or is it remodeling? And this is the important point for you to also know. Once you get to your adult size, you only have remodeling. You don't have displacement anymore. So you've got two processes in the growing phase. Okay, and then as you're an adult, it's still growing, but you only have one process. So adults undergo remodeling their whole life, but they only have displacement when you're younger. Now, what is the meaning behind that when we talk about that? Well, if you have two things to work with, it's going to be more effective, right? So one of the reasons why people say if you're going to try to change the face, the way it's growing, you might want to change it while someone's younger. Why? Well, now you know. Because when you're younger, you can work on two processes. And when you're older, you've only got one. You've only got one. So knowing, if I told you that, and you know this anyway, that adults can have braces, okay? So do you think tooth movement is a displacement process, or is tooth movement really a remodeling process? Remodeling, of course, because adults can have it. So what's happening in kids is they're having displacement and they're having remodeling. But in the adult population, we're just really modifying the remodeling. And it turns out to be, we'll talk more about it, but it's very effective. So, here, when I was showing the movement, if we can get displacement, if we got displacement, and I'm not going to bring these people back up here, but imagine that we could get displacement of this bone, okay? And we could also get periosteal deposition here, right? So it would be additive, because we'd get displacement and periosteal deposition going in the same direction. And in fact, that sometimes happens in the human face. Sometimes the displacement of the bone and the deposition is going in the same direction. However, that's easier to understand. What's hard to understand is sometimes the displacement is going one direction, but the new bone is happening in the opposite direction. Okay? And that's the case for the maxilla and the mandible. The maxilla is easier to understand. The maxilla as a bone is displaced downward and forward. But the maxilla deposition is generally upward and backward. And that's something that you can't figure out just by looking. And that's something that's counterintuitive to what you've always known your whole life. Because you know that kids, their face gets bigger. You know that the face gets bigger. It's getting longer. It's getting downward and forward. But what you don't know is that there's no new bone here in the front. The new bone is in the back. Okay, so you got to memorize it. That's what your patients don't know. Remember I said, that's why kids don't outgrow crooked teeth. Because the new bone, the bone deposition, isn't occurring where the teeth are crooked. It's occurring in the back, right? So what's happening in the back, what's happening in the back of the maxilla, in the very, very back, when you go into, have you been to see the second graders and the sixth graders? Okay. So when you're there, if you look at the second, are you going to go again? Good, okay. So what I want you to do is this time, I want you to be smarter than the last time you were there, right? Because now you know more about growth. And the second graders, you're there to do their 6-year molars, right? And in the sixth graders, you're there to do their 12-year molars. Notice that in the second graders, if you put your finger all the way in the back of their mouth to the end of their molar, there's nothing at the end of that, right? There's no more bone. The bone ends there, right? Maybe you didn't, I say right, I said, now you know, okay. So with the second graders, I want you to put your finger in there, or look in there with your mirror, whatever you're gonna do. But in your mind, get that picture of that last molar, and there's just nothing behind it. I mean, it's just right there. There's a notch, right? The hamular notch, that's where it is back there. So you've got just the end of the arch. But you know now something must happen by the time this kid's in 6th grade. Okay? So by the time they're in 6th grade, something's happened that now you know what it is. What has happened to each one of those children between 2nd grade and 6th grade is their maxilla, the maxilla that had all the teeth in it, has been displaced downward and forward. That displacement then, there was deposition at the back. And that deposition of bone that occurred in the back is now what you see occupied by that second molar tooth. Does that make sense? But it's not the kind of thing the parents are going to understand. It's weird, right? I mean, it's such a weird thing that the new bone would be in the back by the tonsils, right, way in the back. And then it would seem like, why don't you just put the new bone here, right? Why don't you put it right there in the front, because we're growing down forward. It doesn't happen that way. So one of the really key things that you have to memorize is that the maxilla, and you'll see that this is true more or less in the mandible too, but the maxilla is displaced downward and forward, but the remodeling occurs upward and backward of the tuberosity. And you're actually witnessing that change, even though it's cross-sectional data. Okay, we could keep you here for 4 years and you could go back and see the same kids. But I think if you saw 20 kids and you saw that at 2nd grade they didn't have room, and you saw 20 different kids at 6th grade and they all had room, you'd go like, all right, I kind of get it. There's more room in the arch over that time. And now you know what? Displacement and remodeling. Why can't it just be, I'm glad you raised your hand because you want to answer this question. Why can't it just be remodeling? Why can't it just be remodeling? There you go. In other words, bones can't push against other bones. First you got to have the displacement, then you get the remodeling. But it occurs so close that it's not like first we get displacement and then you get remodeling. All right? It's occurring simultaneously, displacement and remodeling. But it can't be just remodeling because you need to have space for bone to grow. Bone can grow if there's no under tension. You know what tension is, that's stretching, right? So if you get displacement, there's a certain amount of tension, and then that can stimulate bone growth. But the bone growth occurs in the back. And if you look at the kids that are in 2nd grade, and they've got crowded teeth here, you see them in 6th grade, that's not going to get any better. They're not going to outgrow that because that's not where they're getting new bone. Okay, I think that's enough for today. You've had a long day. I know you guys were doing stuff and it's 4 o'clock. We might have started a little late, but I think that's pretty much what I wanted to go over today. Next time we'll talk more about maxilla, and then we'll talk about mandible. Before we quit today, questions?
When the deposition is outset of the displacement, is
Yes.
there a specific name for that displacement? Or is it
No,
primary?
it's just primary displacement, downward and forward, and the remodeling upward and backward is based on deposition upward and backward. There's not a different name for it. And when it goes in the same direction, there's not a name for that either. It's just you have to recognize it as you look for it. But you can see that when it goes in the opposite direction, it's gonna look different, right? Okay, other questions? Yes? Quiet for a minute.
Displacement, there are no new cells.
Yes, what she's saying there is perfect. In that, when you get displacement, you don't necessarily have to have new bone cells, right? Because displacement's moving the entire bone. Now, generally, both processes are happening simultaneously, but the displacement process only involves the movement of the entire bone. Yes.
Can you explain why the sinus is also getting enlarged?
Oh, it brings up a good point here. There's a couple, no one knows exactly, okay, why because they're bigger in men than they are in women and things like that. I mean, one reason is for resonance of the voice. And another one is just that idea of the density of the bone, so that, you know, if you're adding bone and you never have any spaces inside, then it gets pretty heavy. So sinuses create space, airspace, basically, in the head. Other questions? All right, well, you guys, no more classes today, right? Okay, is it next week that we have Tuesday? We switch? Okay. Because I think it is, I think it's